You want me to introduce now?
Please do,
Yes.
thank you.
Okay. Hello, everybody. Our first lecturer is well-known, Dr. Samir El-Ansari. He's going to continue his lecture on muscle disorders in the ICU. Welcome, Professor.
Thank you, Dr. Barbara. Good evening, my colleagues. Good evening, everybody. Welcome for our attendees. And Eid Mubarak, inshallah. I am going today to speak about some other problems in concerning muscle disorders, which we can continue now. Last week we speak about some of the most common problems we encountered in our ICU regarding the muscle diseases. We speak about tetanus, we speak about Guillain-Barré syndrome, and also we covered myasthenia gravis. And today we are going to complete the topic, or to some extent cover the most common or famous problems which we face in the ICU. One of the important diseases which we face in the ICU is a critical illness, polyneuropathy, and critical illness myopathy. And actually it is a common problem which we face, especially in patients staying long time in ICU. As we know, this disease is predisposed by several factors, especially sepsis and multi-organ disease, multi-organ failure, excessive use of steroids or aminoglycosides or muscle relaxants. All these predispose to critical illness, myopathy, and polyneuropathy, and sometimes the two overlapping, and the two are present together. Most common acquired neuromuscular condition really in ICU, and up to 50% of patients suffering from sepsis and multi-organ dysfunction. And the clinical features is flaccid limb and respiratory weakness. And of course, the weakness range from mild degree to severe degree, and it poses a problem in weaning. We can't wean the patient from the ventilator, and reflexes is still present even in 1/3 of the patient. If we look to the electrophysiological evidence for this disease and how to differentiate it from the other diseases, such as Barré syndrome or other muscle diseases like myotonia and myasthenia and so on, we will find here preserved sensory response more than 80% of lower limit of normal. And there is some degree of sensory response patent. Reduced motor response, especially compound muscle action potential, will be decreased to less than 80% of lower limit of normal. If we apply train of 4 or repetitive nerve stimulations, we will find low amplitude motor unit potential with early full or normal recruitment of the motor unit action potential. This meaning the action potential is decreased when we apply any stimulus, but the recruitment is regained again, and there is no fade or no post-tetanic potentiation like in cases of non-depolarizing or in cases or in Barré syndrome. Muscle excitability with direct muscle stimulation. Also, there are other causes of acute myopathy should be excluded for differential diagnosis from the critical illness. For example, porphyria, acute massive intoxications of heavy metals, vasculitis, autoimmune diseases. And if we are don't sure if it is not, we have to take muscle biopsy, and will be consistent with myopathy and myosin loss, and with some necrosis in some patients. The pathogenesis of critical illness polyneuropathy and critical illness myopathy, there are several factors really, some of them related to microvascular alterations, metabolic alterations, electrical alterations, and bioenergetic failure. And all these are common causes for muscle myopathy in the ICU. For microvascular alterations, as we know, most of the septic patients exhibiting vasodilation, increased permeability, endoneural edema, hypoxemia, and at some time extravasation, cytokine production too much. And so the research now how to improve this muscle condition and to avoid the critical illness, they are playing on cytokine production and how to decrease this cytokine production and to avoid the hypoxemia and the predisposing factors to intensive myopathy. Other metabolic alterations which can predispose hyperglycemia, and we find the patient who exhibiting normoglycemia or controlling of blood sugar really not suffering too much from critical illness myopathy. The incidence is low. Also hormonal imbalance, hypothyroidism, hyperparathyroidism, all these causes critical illness myopathy. Hypoalbuminemia, amino acid deficiency, activation of proteolytic pathway also predispose. Electrical changes which can affect and predispose to intensive myopathy, ion channel dysfunctions. These are calcium channels, sodium channels, potassium channels, all the channels which are regarded or involved in the process of acetylcholine generation and acetylcholine action and combination with the acetylcholine receptors. All channel channelopathy affect the muscles, of course. Cell depolarization, cell inexcitability, altered the calcium homeostasis, a change in the exciting contraction coupling also affects the muscle at the end. Also, the bioenergetic failure due to antioxidant depletion, and so one of the treatment of this condition is to give antioxidant. Reactive oxygen species generations as hydrogen peroxide and superoxides predispose, mitochondrial dysfunction, apoptosis, all these factors predispose to critical illness, myopathy, and polyneuropathy. And as we see from this diagram, the pathological classification of critical illness, polyneuropathy, and myopathy, we can see here the overlapping in some of patients from both critical illness, polyneuropathy, and myopathy. And the most triggers or the types or predisposing factors summarized here may be normal or mild necrosis and exhibiting some rhabdomyolysis. We can see in other patients marked necrosis with acute myopathy with diffuse necrosis, or maybe some cachectic myopathy due to unusing the muscles or denervation atrophy. Like in this case, we can find type 2 fiber atrophy. Also, we can see acute myopathy with scattered necrosis type, or we can show loss of thick filaments and thick filament myopathy. And so these are the most common types of critical intensive care myopathy. This table really is very important for differentiation between the critical illness polyneuropathy and the Guillain-Barré syndrome. It's very important. In critical illness polyneuropathy, with the patient always suffering from sepsis and multiple organ failure before the onset of muscle myopathy. The onset of disorders is usually after intensive care unit admission and often characterized by fairly symmetrical limb weakness, sparing cranial nerve. Cranial nerve mostly not affected in critical illness myopathy. Sensory deficit is less prominent in cases of critical illness polyneuropathy. The cerebrospinal fluid is usually normal. In contrast to Barré syndrome, we find the protein is high with normal cells or less than 50 cells per cubic liter. Usually, there is axonal motor and sensory polyneuropathy in intensive care myopathy or in critical illness polyneuropathy. No, for magnetic resonance, we can't find any positive data, but in Barré syndrome, we can find the enhancement of the spinal nerve root, maybe due to inflammation and the macrophage migration to the nerve and demyelination and so on. Biopsy can answer the questions. Primary axonal degeneration here with distal peripheral nerve without inflammation, but in Barré syndrome, we can find demyelination and find some sort of inflammation of the nerve. And as we discussed before, in Barré syndrome, the patient may exhibiting the disease may be manifested by several manifestations. It may be motor only, may be motor and sensory, may attack some area like the cranial nerve only, may be affecting the lower half of the body, paraparetic only. And so it takes different forms, as in addition to Miller-Fisher syndrome, there are different types of Barré syndrome. Treatment in intensive care myopathy, no specific therapy, usually antiseptic treatment and nutritional support and antioxidant and so on. But in Barré syndrome specifically, you can use plasmapheresis and intravenous immunoglobulin is the main treatment lines for Barré syndrome. The outcome also in CIP is recovery may be spontaneous and of variable timing, 50% of patients with full recovery. In Barré syndrome, more than 75% complete recovery, but some patients exhibiting some sequelae and some complications, of course. In all muscle diseases, as we will discuss, all sharing a common problem actually in the ICU. They are sharing the DVT complications, and so we have to care from DVT occurrence. We have to turn the patient and give prophylactic anticoagulant. The patient also suffering from airway problem, and so you have to be careful in evaluating the patient daily and every hour to avoid any airway failure or any respiratory failure. In Barré syndrome, of course, at the start, we can withdraw CSF sample and we can see increasing the protein in CSF, but without peliocytosis, without increasing cells. As I told you, the cells less than 50 cells per microliter. And always Barré syndrome follow some sort of gastrointestinal infection, and especially the Campylobacter infection. In 25% of patients now suffering previous Campylobacter infection, common for disposing to Barré syndrome, or suffering from some sort of respiratory infections or vaccination, especially vaccination against influenza. Treatment of CIP or critical illness polyneuropathy and critical illness myopathy, nutritional support and nutritional therapy. And this is very important really. The patient, all muscle disease patient or suffering from muscle disease exhibiting some sort of high catabolic rate. And so they need more protein diet and more energy. In the adult, we can give up to 3,500 kilocalories per day. Antioxidant therapy, vitamin E, selenium, vitamin C, all these are very important. Also hormonal therapy, especially testosterone derivatives, are essential in ameliorating the disease. Intravenous immunoglobulin in some research and some papers may support the patient and may delay the development of CIP and CIM. Insulin therapy, really, we have to control the blood sugar. But we have to avoid the restrictive or strict control of blood sugar to avoid the hypoglycemic attacks which occur in restrictive lines of therapy. We have to decrease the blood sugar to maintaining it less than 10 millimole per liter. I think this is enough. Physiotherapy as early as possible is very important. The physiotherapy and the electric nerve stimulations for the muscle are all very important for avoiding the progress of critical illness myopathy. As hyperglycemia is a risk factor for critical illness in general and polyneuropathy and myopathy specifically, strict glycemic control and with insulin should have a beneficial effect on such patients. We have to know also the additional actions of insulin and the advantages of using it, including anti-inflammatory effect, endothelial protection, improvement of dyslipidemia, and neuroprotective effect, and is also an anabolic hormone, of course. And as I said, muscle disease, all patients always suffering from catabolic state, high catabolic state. And despite its effectiveness, intensive insulin therapy increases the risk of hypoglycemia and so increases the risk of morbidity. And most of the research work supports the using of liberal or avoiding restrictive and just keeping the blood sugar to less than 10 millimole per liter, about 170, 180 milligram per cent. No improvement in muscle strength was achieved with a strict glycemic control, but on contrast, they increase the morbidity of the patient. Very important to start active and passive therapeutic exercise for those patients, early rehabilitation, early passive exercise, combining with mobilization with physiotherapy. Also, electrical muscle stimulations, a form of exercise and mobilization that doesn't require patient's active participation and can thus be applied to immobilize the patients. We can stimulate the vastus lateralis, vastus medialis, and even we stimulate some muscles and not the other muscles, it improvement of the other muscles and increase the blood supply and improving the patient power. And so electric muscle stimulations, very important, done in sessions with certain amperes and done by the physiotherapist. The program is divided into 4 phases for physiotherapy. Phase 1, phase 2, 3, and 4. Phase 1 includes critically ill patients who are in unstable state, unstable conditions at the time and are restricted to bed rest. They are resting on bed. They can only be out of bed in a stretcher chair, just letting him sit on a stretcher chair daily for some time because of their inability to bear weight. Second phase, after that, after the patient hemodynamic state and the condition improving, we can training him with walker, with pre-walking activities and walking re-educations for the patients. And this is very important, really. It has a psychological effect and it promotes the anabolic state and ameliorates the incidence of the DVT and so. Phase 3 start progressive walking re-education program and the functional training outside the room to improve the endurance and the functional mobility. No objection to help the patients to go out of bed and go out of his room and go out to outside the ICU to an open area and open air. These are very good methods of management for such bedridden patients to avoid these critical illness myopathy. Phase 4 prepare for hospital discharge, and in this phase we have to rehabilitate the patient both psychologically and physically, and I think we have to send him to rehabilitation center if we don't have these centers in our hospital. The future therapeutic intervention should be targeted at, and the research work now concentrate on such factors to ameliorate or to decrease the incidence of CIM and intensive care neuropathy. Pro-inflammatory cytokines, how to decrease it, how to antagonize it, free radical pathways, muscle gene expression, ion channel function, calcium and potassium and sodium and so on, all the channels, and proteolytic muscle protein mechanism. All these factors are concentrated on it now for treatment and management of such patients. Early application of intravenous immunoglobulin may prevent or mitigate the critical illness polyneuropathy. However, this awaits confirmation in large randomized controlled studies. Nutritional supplementation in combination with a short course of nandrolene decanoate or testosterone derivatives may enhance the gain of respiratory muscle function in depleted patient with chronic, especially in patients with chronic obstructive airway disease and coronary or cardiac disease. The other problems which we face regarding or related to muscle problem in ICU is the prolonged effect of neuromuscular blockade. Actually, it is a common problem, especially for patients coming from OR with residual effect from neuromuscular non-depolarizing or depolarizing, and also for patients who, as such patients as RDS or patient on ventilator, and we give some muscle relaxant to just decrease or improving the rest by the muscle compliance and to aid the ventilation and decrease the airway or the airway pressure. Prolonged effect of neuromuscular blockade may be transient weakness. We can antagonize the drug either spontaneously or with anticholinesterase like nistagmine, or and if we see the electrophysiology of neuromuscular transmission blockade, and also we have to be oriented with the pharmacokinetic of the muscle relaxant drug, either the non-depolarizing muscle relaxant like vicuronium, pancuronium, cisatracorium, and the pharmacodynamic action. Because some patients may be exhibiting some problems in excretions, renal problems, hepatic problems, and so the excretions of the drugs will be slow and will be prolonged effect of the muscle relaxants. And we must know, most of the muscle relaxants are accumulated. And so if we use muscle relaxant for helping ventilated patients, we have to use small doses and titrating it and going down with the dose by time, and avoid and we have to know the condition of the patient. Most of our patients are either exhibiting respiratory acidosis, metabolic acidosis or alkalosis, some electrolyte problems, and all these factors prolong the muscle relaxant effect. Also, there are another problems in using muscle relaxants in ICU. Don't use too high doses. No need for complete blockade of neuromuscular junctions. You need just to keep the muscles relaxed to help the patient to be ventilated and not fighting the ventilators. And also at the same time, when using muscle relaxant, don't forget some items, some important points. You have to give sedation, good sedation for these patients. You have to give good analgesia for these patients. You have to ambulate this patient. You have to anticoagulate. You have to suspect these patients will be subjected to DVT more than other patients not using muscle relaxant, because the muscles are highly relaxed and flaccid. For example, vicuronium in renal failure due to active metabolism will give me prolonged effect. And so prolonged effect of neuromuscular could not affect the creatinine kinase. Creatinine kinase is not so high in such patient. Muscle biopsy will be normal. But we have to consider and to avoid the conditions which can prolong the neuromuscular blocking effect or prolongation. Hypothermia, which is very common in ICU. Hypothermia, and one of the main factors which prolongs the effect of non-depolarizing muscle relaxant. Metabolic dearrangement, hypocalcemia, hypermagnesemia, hypokalemia, hypothermia, respiratory acidosis, metabolic alkalosis. All these factors predisposed to prolongation of neuromuscular effect. For example, pancuronium and vicuronium undergo metabolism by deacetylations, and the liver is essential for its metabolism, so avoid it, of course, in liver disease. Rocuronium and vicuronium get excreted via hepatobiliary system, and so if your patient exhibiting hepatic problems, you have to avoid. If your patient exhibiting some problem in renal and hepatic, you have to use another muscle relaxant not excreted by the liver or kidney, and you have to use atracorium or cisatracorium, which are degraded by spontaneously, degraded by Hoffman and ester hydrolysis. And I say these two reactions depend on the pH and depend on the temperature of the body. So you have to be oriented with the pharmacokinetic of your drugs, especially if you are going to use infusion, muscle relaxant infusion for your patient. The other point which is important, and I want to stress on it, the monitoring of neuromuscular function, which is very important for patients needing neuromuscular blocker infusion in ICU. No need, as I said, for complete 100% paralysis of the muscles. We're not needing for this. Of course, in critically ill patients, the sensitivity and the metabolism of muscle relaxant is changed, especially in critically ill patients due to, as you know, to affection of the renal function and the hepatic function, and also to alteration in the protein content of the serum. We have a common test and famous and popular test for monitoring the neuromuscular function, which is the train of four. Train of four. 4 stimuli, you apply 4 stimuli. 4 sequential stimuli over 2-second period, and we have many instruments now using it for application of this train of thought. You must be monitoring the neuromuscular function every 2-3 hours or prolonged according to the patient. This is a single twitch as we see, and this is a train of four stimuli. And if the stimulus becoming weak like this, it is, we call it fade on train of four, fading in train of four. And this is a characteristic figure we get from non-depolarizing muscle relaxants, fading of train of four. Fade may progress to no twitch if enough non-depolarizing muscle relaxant is given. If you give too high dose, of course, you will abolish even the force stimulus will be absent, of course. For nerve monitoring a train of four, if you abolish R4, you get 75% receptors blocked, or R4 is affected, 75% receptor blocked. If the third response is absent, 85% receptor blocked. If the second receptor is blocked, the second response, 90% receptors blocked. R1 disappear at 95% receptor. We need 95% block only during intubation, especially in difficult cases. But 90% we can get it in surgical, under surgery, during surgical interventions, in cases of when the surgeon need muscle relaxations. But in cases of ICU, no need to exceed 75% or even less than 75%. For nerve monitoring, we can use also double burst test. And if the second one is fading like this, we call it fading. And we have to differentiate now between the depolarizing and the non-depolarizing nerve stimulations. Every group, as you know, depolarizing like saxamethonium and decamethonium, which contains 2 molecules of acetylcholine, and when you apply it, it making the muscles depolarized, persistent depolarization, and so the receptors becoming refractory to any action potential after that. If you repeat the muscle relaxant, depolarizing muscle relaxant, or depolarizing dose from saxamethonium, you will get phase 2 block. At first, if you give your dose depolarizing dose from saxamethonium, you will get decreased or depressed the action potential. If you increase it, you will get a second block, which will mimic in its characteristics the non-depolarizing muscle block, excepting the fading, excepting the post-tetanic potentiation, and so on. And so avoid saxamethonium or depolarizing muscle infusion, a muscle relaxant, or repeated doses from saxamethonium. Otherwise, you will get the second block, which may be difficult to analyze. This table differentiates between depolarizing and non-depolarizing. As I said, depolarizing, excepting phase 1 block from first dose, it will decrease the action potential amplitude. This is the normal action potential here after muscle relaxant, after saxamethonium injected. And if we repeat the saxamethonium 2 times, 3 times, we will get fading like non-depolarizing muscle relaxants. And we will get also both the tetanic potentiation here in non-depolarizing and also in the phase 2 of depolarizing muscle. This nerve stimulation actually helps us for detecting the degree of relaxation of our patient, demonstrate how much our patients need muscle relaxant. As I said, muscle relaxants accumulating by time, and so you have to be guided by motor nerve stimulation to guide you to the subsequent doses. You have to decrease the doses if you get third or fourth stimulus abolished or diminished. You have to decrease. If it is present, you have to increase, and so guide you to titrate your dose of muscle relaxant to avoid any complications to your patient. Placement of nerve stimulator or nerve monitor, we can use the ulnar adductor releases, we can use the facial orbicularis oculi, we can use the posterior tibial flexor hallucis, and we can see here we apply to ulnar nerve monitoring and just looking to the thumb for any contractions. through ulnar nerve stimulation, and we must be sure we stimulate the ulnar nerve, not the muscles, not the median nerve. If we stimulate the ulnar nerve purely, we can get this movement of the thumb, and you can predict this movement of the thumb through vision or through tactile sensations. So you put your hand here and you see the strength of contraction. If you get the other finger contracted, you is really stimulating the median nerve, or you may be stimulating the muscles and ulnar nerve, and it is not correct, and you have to adjust your electrodes to get the actual response from the thumb, stimulating the ulnar nerve, not the median nerve, not the muscles. We can also monitor the nerve action from facial nerve monitoring. Facial nerve monitoring, and the index here is the orbicularis oculi contraction, as we see here, orbicularis oculi, and we apply it to the facial nerve electrodes here, and we get the response. Also, we can apply it to the posterior tibial nerve, and we can get the flexion of the pectoral. If no or one twitch, the dose should be reduced by 10%. If it is 3 or 4 twitches are present, the dose can be increased by 10%. You have to titrate gradually up and down and to give the actual dose or the optimum dose of muscle relaxants. Daily discontinuation of neuromuscular blockers for a few hours, very important and mandatory also. Like this sedative, you know, to wean your patients, and you know the bundles, we have to subject the patient daily for SBT and SAT, which is spontaneous awakening trial or spontaneous breathing trials. Also here, we have to stop the muscle relaxant daily and evaluate your patient, his muscles will recover. All paralyzed patients require the following sedation, and don't give muscle relaxant and depend on it for paralyzing your patient, and your patient is conscious. This is highly traumatic and highly causing psychological upset to your patient. You have to give sedation, good sedation and analgesia during muscle relaxation. Also, of course, any patient will need good ventilation, suctioning, artificial tears, take care of bed sores, anticoagulation for DVT, and so on. Frequent turning the patient and prophylactic deep venous thrombosis, prophylactic, very important for such patients. The other problems, we shift now to other problems, which is disorders of transmission at the neuromuscular junctions. As we know, the neuromuscular junction consists of peripheral nerve, presynaptic cleft, synaptic cleft, postsynaptic. There are many diseases which affect the presynaptic, others affect the synaptic cleft, others affect the postsynaptic. As in myasthenia gravis, as we know, affect the postsynaptic receptors, antibodies against postsynaptic receptors. In botulism, it will affect the, as we will see, affect the presynaptic calcium vesicles and also the presynaptic receptors. This is a neuromuscular junction, peripheral nerve, and we discussed already the peripheral nerve disorders in, for example, Barré syndrome, and we shift now to neuromuscular junctions, which, as I said, consist of presynaptic, synaptic, and postsynaptic receptors. Presynaptic dysfunctions as Lambert-Eaton syndrome and botulism, postsynaptic dysfunction, myasthenia gravis, and I speak already about myasthenia gravis. And I told you it is due to antibodies against the postsynaptic receptors, and it affects mostly the cranial muscles, and going down, causing dysphagia, causing dropping of eyelids, and increasing by time, by repetitive of movement, and so on. And it may be okay at early morning and becoming weak at late afternoon. And the treatment, we know we have to give plasmapheresis, or we can give immunoglobulin and the anticholinesterase, which is pyridostigmine, the long-acting, and we have to combine with it, as I said, glycopyrrolate or atropine to decrease the parasympathetic or muscarinic effect of these anticholinesterase drugs. Today, I am going to speak about another problem affecting the neurotransmission, which affects the presynaptic, is the botulism. And all of us know the canned food and its complications and the botulinum toxins, which causes, which is most toxic substance known produced from bacteria called Clostridium botulinum. And as we know, the toxin inhibits the vesicular fusion of the calcium vesicles. And so the release of calcium at the presynaptic area is impaired and blocking the neurotransmission release at cholinergic terminals. Botulinum toxin types, we have many types of botulinum toxin really, A, B, E, F, and H. The other D and C affecting other birds and mammals, and H mostly from, we find it from fish, consuming fish infected with Clostridium disease. As we see here, patient exhibiting botulism, there is weakness of the eye muscles and dropping of eyelids and dilated, non-moving pupils, showing the picture not shown here. But the patient is fully conscious, not affecting the consciousness, and the paralysis or weakness can be descending after. The toxin is evaluated as potential biowarfare agent in 1960, and some countries try to utilize it. Unlike other straight toxins, botulinum toxins appear to cause same disease after inhalation. Could be inhaled, could be through oral ingestion or injection, especially patient using heroin and so on, they can inject wrongly through the skin. There is no natural inhalation botulism. Types of botulism, there is infant botulism, which usually we see in baby less than 1 year. They can swallow botulinum spores, and the spores germinate into bacteria in their intestine, especially getting it from dust and soil and honey. And so we avoid giving baby honey before 1 year. Bacteria can then release the toxins and infect the. This is the infant botulism. Another type, which is wound botulism, and botulism spores can get into the open wound and slowly reproduce, eventually release the toxins. And this type, you can see it in patient or people injecting black tar heroin into their skin rather than their veins. Inhalation botulism, and this is very toxic really and killer. Some nations have tried to make biological weapons that would spread a deadly form of the toxin into the air, and even small quantity of it can cause problems to the patient. The other type, adult intestinal colonization, the rare form of botulism that occurs when the bacterium colonizes the digestive tract of the adult. Iatrogenic botulism from cases of excessive using of Botox and sometimes causing botulism and weakness. Foodborne botulism in all canned food, and all food must be boiled to kill the vegetative organism. And for the spore to be killed, really, it needs a high pressure, and more than 100 degrees centigrade. Botulism doesn't grow in acidic food with a pH of less than 4.5 or less. But any canned fruits or canned vegetables or foods, and if we see any containers bulging or getting air, just opening it, and some air, we have to avoid using it, even testing it, avoid testing it. Signs and symptoms of human inhalation botulism. Symptoms typically start 12 to 36 hours after exposure. After the 2 days, 1 day, 2 days, it starts the patient complaining from weakness, mucus in the throat, difficulty in swallowing solid food, blurring of vision, diplopia, ptosis, sarsa, dysphagia, and descending weakness with respiratory compromise and need artificial ventilation. Primary clinical descending paralysis with prominent cranial nerve involvement and autonomic dysfunction, especially in gastrointestinal one. Through nerve physiology and electromyography, we can diagnose it. There is here more there is post-tetanic potentiation. High frequency repetitive nerve stimulation produces an incremental muscle response, increase muscle growth, post-tetanic potentiation here. In contrast to Barré syndrome, post-tetanic fade. In contrast to critical illness myopathy, fading. Non-depolarizing muscle relaxant, post-tetanic fading. But here you can get post-tetanic potentiation due to accumulation of acetylcholine with repeated nerve stimulation. And just the toxin recovered from the serum and stools, inhaled toxin is fatal in too small quantity to be detected. Very toxic, really. Diagnostic tests you have to depend on clinical evaluations and also toxins from the serum and from differential diagnosis from other muscle diseases through brain CT scan, through CSF examination. No increase in protein, as in contrast to Barré syndrome. Electromyography, hydrophonium can differentiate, of course. In hydrophonium, if you inject it in small dose, 2 milligram or 8 milligram, you will get improvement in cases of myasthenia gravis. But in contrast, in proteorism, if the toxin is identified in the food, stomach, vomit, feces, or intestinal contents, a definitive diagnosis can be made. Treatment, Anna, we have to give botulinum, botulism immunoglobulin, especially for baby immunoglobulin. No rule for antibiotic except in cases of wound or gastrointestinal colonization. We can give antibiotic with immunoglobulin. There is other diseases or other patients exhibiting some acetylcholine binding or blocking of acetylcholine binding, and we can saw them in the ICU, like Bangarotoxins, the principal ingredient of venom produced by some type of snakes. Also, which blocks the acetylcholine receptors here. Also, curare and non-depolarizing muscle relaxants all work by competitive inhibition of these acetylcholine receptors. Also, the other blocking other toxins blocking the acetylcholine release in cases of alpha-toxin from black spider produces indiscriminate dumping of synaptic vesicles and blocking the receptors. Also, some fish, snails, contain some toxins like gamma conotoxins can block the receptors and giving muscle relaxation. The other problem which we can see in the ICU, especially during biowarfare, organophosphate poisoning, which is as acetylcholinesterase inhibitors, which is permanent or irreversible acetylcholinesterase inhibitors, and we making the receptors depolarized and persistent depolarization and the contractions of the muscle. And so you have to use a specific antidote for this organophosphate poisoning, which is like sarin or the myostigmine drugs or pyridostigmine, which are anticholinesterase drugs. You have to antagonize in such situations both the muscarinic and the nicotinic receptors. These figures show the end play potential summary. As it is stimulated within seconds or within milliseconds, it will be hydrolyzed by acetylcholinesterase. Just acetylcholine released from the vesicles at the end plate and the trigger and activating the acetylcholine channels and opening it and the action potential started, it will be paralyzed rapidly by acetylcholinesterase and removing the acetylcholine. If acetylcholine persists or acetylcholinesterase is not present, like in cases of organophosphate poisoning, acetylcholine will accumulate, acetylcholine will depolarize, and the action potential will be persistent. And so the muscles becoming refractory for any more action potential, no effect of other acetylcholine action. And they will be paralyzed in a state of depolarization. And this is the action of organophosphate poisoning. In such situations, in organophosphate poisoning, your patient will be suffering from acetylcholine action, excessive acetylcholine action, which are muscarinic and nicotinic. Muscarinic, like patient becoming pupils constricted, meiosis, blurred vision, lacrimation, all secretions of the body are stimulated, abdominal pain, diarrhea, vomiting, urinary and fecal incontinence, bradycardia, like the effect of excessive dose of neostigmine. If you give your patient too much dose of neostigmine. In cases of myasthenia gravis, for example, there are, as you know, myasthenic crisis and cholinergic crisis. This is a cholinergic crisis, organophosphate poisoning. In addition to nicotinic stimulation, the patient will suffering from muscle twitching, cramping, weakness, altered mental seizures activity, and so on. And so we have to block both the muscarinic and nicotinic. We block the nicotinic receptors by pralidoxime, specific antagonizing the organophosphate, and blocking the muscarinic by frequent doses of atropine. This is a problem with organophosphate poisoning. Another problem we can fentanyl-induced thoracic rigidity, and I think most of our colleagues know if you use fentanyl or sofentanil or alfentanil in induction or for intubation, you will face with a great problem, which is the muscle rigidity. You will find your patient exhibiting too much rigidity, chest rigidity, and even laryngeal spasm from the effect. And so we have to use with it muscle relaxant, or we using with it benzodiazepine to relax your patient to avoid, or we can use naloxone or neuromuscular blocking agent to facilitate intubation. Other muscle disorders which I wanted to mention, as we know, we have more than 30 types of muscle disease, and we have more than 600, even more than 600 causes of neurological problems which we can face and which we can put problems in the ICU for airway and so on. We just give just types of examples of types of muscle diseases. There may be hereditary muscle disease as muscle dystrophy. We can see the muscles hypertrophy, but weak at the same time. Muscle channelopathy, which affects the channels which are responsible for action potential, starting from calcium channels, sodium channels, potassium channels, and so on. Mitochondrial myopathy, metabolic myopathy, acquired muscle diseases like inflammatory myopathy like dermatomyositis and polymyositis, endocrine and toxic myopathy, just in case of hyperthyroidism or hypothyroidism, hyperparathyroidism. Infectious muscle diseases also are. Diagnosis of muscle diseases in general, we can depend on creatinine kinase, we can depend on electric physiology and electromyography and the muscle biopsy and genetic testing if we have genetic lab. For example, Duchenne muscular dystrophy, which affect due to gene affection in children less than 6 years, and it affects an important protein which is called dystrophin, and it is absent in the muscles, and so the muscle becoming bulky and weak, and it is a progressive disease really leading to muscle weakness and leading to these typical pictures which are bulging abdomen, calf muscles are bulging but weak, the patient can't go up from sitting position. All these manifestations we see, and this is an example of genetically muscle disease, Duchenne atrophy. And if we have immune staining for dystrophin, we will find no staining here in Duchenne dystrophy, but we see here staining of the dystrophin in cases of normal muscle. Muscle channelopathy, as I said, the myotonia, which is difficult in relaxation, the patient's muscles contract, but he can't relax after contraction. Myotonia and familial periodic paralysis are hereditary muscle channelopathy, like periodic hyperkalemic and hypokalemic paralysis, and it affects, as I said, sodium, potassium, calcium, and chloride channels, and they give at start maybe hyper-excitability. After by time the patient becoming hypo-excitable and the muscle weak and not excitable. For inflammatory muscle disease, we know, for example, dermatomyositis and polymyositis, with dermatomyositis associated with skin manifestations, also inclusion body myositis and other systemic autoimmune diseases. This dermatomyositis associated with skin manifestations. polymyositis, and also may be associated with cardiac abnormality and interstitial lung diseases. For endocrine and toxic myopathy, don't forget corticosteroid, alcohol. Don't forget some drugs like statins affect the muscle power and the muscle tone and keep giving myopathy. Endocrine myopathy, don't forget hyperparathyroidism, adrenal insufficiency, hypothyroidism. Don't forget multiple sclerosis, and according to demyelination, which occur in which area may give you many different pictures according to site of demyelination, maybe visual, maybe paralysis, maybe muscle weakness, maybe bladder dysfunction, maybe intestinal problems, constipation, diarrhea, and so on, coordination, according to site of demyelination of the nerves which occur. And again, at the end, I want to say again, don't depend on blood gases and pulmonary function tests for evaluation your patient exhibiting muscle disease. You have to depend on your clinical evaluation at first, and very important clinical evaluation. Hypercapnia don't occur except at the end of the state, at the extremely late finding in this context. So don't wait for your patient to exhibiting hypercapnia. This meaning the patient about to arrest. You have to manage the airway early before that. Good luck and thank you.
Thank you, Prof. Barbara, are you still here?
Yes.
Barbara?
Yes, I'm here.
Okay.
Do we have some questions for Dr. El-Ansari? I believe there's at least one here.
Yes.
It says, Professor, what would you keep the duration of muscle blocking infusions for patients in the ICU who are under mechanical ventilation?
Try to withdraw as soon as possible, as early as possible. Don't delay infusion of muscle relaxants. Prolonging infusion carry many complications for your patients. Just using it instead of refractory hypoxia. Refractory and with small doses, please. But to assess the time may be difficult to assess the time.
Okay, there's another question for you, Professor. Which type of anesthesia is preferred in multiple sclerosis?
In?
Which type of anesthesia is preferred in multiple sclerosis?
In multiple sclerosis?
Yes.
Better to use inhalation anesthesia. Or regional, of course, regional block first, regional anesthesia, followed by inhalation. Avoid muscle relaxant.
Okay. Are there some more questions out there, please? I have one for you then. Do you use Sugammadex in your ICU for any of the patients that have had prolonged muscle blockade?
Again, I don't hear.
Sugammadex, the medication Sugammadex.
I don't hear the questions really.
Do you use medication Sugammadex at all in the ICU to reverse muscle blockade?
Really, I'm not using it.
Okay, very good. Here's another question from the audience. Is there any practical algorithm for diagnosing muscular disease?
Of course, I just give some examples of muscle disease, but there are algorithms and classifications, good classifications for muscle disease. But I just mentioned some examples of muscle disease, and I started from the last lectures from brain, peripheral spinal cord, peripheral nerve, and till the muscles itself.
Very good. Here's another question from the audience, Professor. It says, in Guillain-Barré syndrome, are you in favor of early or late tracheostomy?
Depend on the clinical situations, and as I said, in Barré syndromes, it presents with different varieties. Some types affect the cranial nerves early, and so we have to intubate early. And some affect the muscles, the lower half only, and some affect the shoulder muscles, and others affect sensory nerves only. And so we depend on the clinical situations. But if your patient, you suspect he will stay for more than 12, 14 days intubated, you have to make tracheostomy from start.
Very good. Thank you, Professor. I think that's all our questions. I guess we're ready to move on to Dr. Hashim.
Hello.
I'll tell a little bit about Dr. Hashim, consultant and lecturer of cardiothoracic anesthesia at Alexandria University and anesthesia department at Freeman Hospital in United Kingdom. And he is going to lecture on management of thoracic aortic disease and aneurysms. Welcome.
So thank you so much, Dr. Barbara, for the nice introduction. Thank you very much, Dr. Saad, and all the panelists for this great opportunity. So today I'm going to touch the anesthetic management of thoracic aortic diseases, and I'll try to touch the basis and try to be like as much as possible to cover the topic, which is a huge one. So the introduction, we all know that arterial diseases are either coronary artery diseases, peripheral arterial diseases, or aortic diseases. Aortic diseases are aortic aneurysms, acute aortic syndromes with its types we're going to discuss later, atherosclerotic diseases, inflammatory affections, genetic diseases such as Marfan syndrome, congenital abnormalities, which includes the coarctation of the aorta and the bicuspid aortic valve. What's the magnitude of this problem here? Recently, overall global death rate from aortic aneurysm and aortic dissection increased from 2.49 per 100,000 to 2.78 per 100,000 inhabitants between 1990 and 2010. And this burden increases with age and in men as well. Treatment should be, in these cases, directed towards new modalities, which are now approaching like aortic clinics, which are patients should go to the aortic clinics, which are highly specialized in these diseases, which have as well a multidisciplinary team which are responsible for these patients. And it goes without saying that the hospital volume outcome relationship is important. The more the cases they do from the aortic surgeries, the more the better the results. And these are also referred as aortic teams. So aortic clinics and aortic teams are now important. So if we look at this case scenario, 65 years old man with a history of smoking, hypertension, presenting to sharp tearing pain for the past 24 hours, also complaining of worsening cough, wheezing, dyspnea over the last 3 hours. How to approach this patient? And what's your anesthetic plan? Preoperative assessment, optimization, intraoperative management with minimizing the risks and the adverse outcomes, and the postoperative plan are the 3 important things. We are going to discuss this in a guide of the following guidelines: 2014 European Society Guidelines and 2010 American Heart Association Guidelines, as well for the thoracic aortic diseases management. We should always refer to this, which is the level of evidence with the class of evidence and the level of evidence. And this is very important in our discussion as well. What are the anesthetic considerations for the case of the thoracic aortic surgical patients? So the pre-anesthetic assessment here is very important. What's the urgency of this operation, and what is the pathology, and what the anatomic extent of the disease? Are we going to approach median sternotomy or thoracotomy? Is it the mediastinal effect happening for these patients? Is the compression and mediastinal syndrome, for example? Is there any way compression or deviation which is affected before going to surgery? And we should also touch the pre-existing or associated medical conditions and review them very well. So if there's an aortic valve disease or not, cardiac tamponading, coronary artery stenosis, cardiomyopathy and heart failure, cerebrovascular disease, pulmonary disease with the affection of either the pulmonary bronchioles, bronchi or the lung itself, which will affect the postoperative course and the intraoperative course as well. Renal insufficiency is very important, and esophageal disease, if there's any contraindications to using the TOE, which is one of the cornerstones of the management. Coagulopathy is very important because these patients may need spinal CSF drainage, introducing spinal catheters, and they are difficult management, prolonged bypass, time, hypothermia, deep hypothermic circulatory arrest, and this all will affect the relation of the patient. So if this patient is starting with a coagulopathy or a liver hit or liver dysfunction, this will be affecting our management and will be difficult to manage as well. And any prior aortic operation is the redo operation, which is more difficult always. Is these patients or any medications such as warfarin, antiplatelet therapy, antihypertensive therapy before the surgery? And we usually find this very complicated picture of this patient in theater, lots of things, bis, NIRS, transesophageal echo, Swangans, lines coming from all types of the patients, and we don't see the back of the patient here. There's always the spinal drainage catheter and the other monitors that we use for these patients. So we almost use all the monitors that we know. What's the anesthetic management? So hemodynamic monitoring here to start with is very important. We should use a proximal aortic pressure line, either in the right hand, and the distal aortic pressure line if it is distal to the procedure known. So we have to discuss the procedure with the surgeon and know what's the procedure going to be and what type or what part of the aorta is going to be operated upon. Central venous pressure is very important. If this patient is tamponading, and if this patient it reflects the right atrial pressure, and its central venous pressure is very important if we are using retrograde cerebral perfusion as well. Pulmonary artery pressure, cardiac output, especially in the post bypass and in the post-operative period management. TOE is the cornerstone. Neurophysiological monitoring that such as EEG, somatosensory evoked potential, motor evoked potentials, jugular venous oxygen saturation, which has now NIRS has replaced it almost, and lumbar cerebrospinal fluid pressure and body temperature as well. We may use double lumen endotracheal tube or bronchial blockers for one lung ventilation to facilitate the operative field and facilitate the surgery as well, and this will lead to better dissection and less complications. Potentiality for bleeding, should use large bore intravenous cannulas. Blood products all available. For us, antifibrinolytic therapy should be available. So we use a protein infusion from the beginning of these cases till the end of these cases as well. And this is very important. And the antibiotic prophylaxis, these patients are very liable to infection. Post-operative care and the complications are always the same: hypothermia, hypotension, hypertension, bleeding, spinal cord ischemia, which is very important. It should monitor for 48 hours post-intervention, stroke, and renal insufficiency, respiratory insufficiency, phrenic nerve injury, and the diaphragmatic dysfunction. And these both are very important because these patients may be difficult to wean from ventilator, and the main cause may be these injuries to the diaphragm or to the phrenic nerve, and may need tracheostomy and long-term management in the ICU. Recurrent laryngeal nerve injury. Sometimes we find patients, we already see them in the preoperative period assessment or preoperative assessment, and after a couple of hours in the OR, we saw them that they start to be have hoarseness in their voice, and we should expect there's a bleeding, aneurysm, for example, compression on the recurrent laryngeal nerve. So whenever you have this recurrent laryngeal nerve injury, hoarseness of voice, you should suspect that there is pressure on this from the aortic side. Pain management is very important as well. And so what are the medical management appropriate for these patients? Always you have to target these patients not to have further further deterioration of the pathology. So for dissecting aneurysm, well-controlled blood pressure, decrease the contractility is very important. Leaking aneurysm, same hemodynamic principles as dissecting aneurysm. So we should decrease the heart rate, decrease the blood pressure, and with this we usually use beta blockers as the first line and plus or minus vasodilators, but don't ever use vasodilators on their own for hypertension, because this leads to reflex tachycardia and further deterioration of the patient. Ruptured aneurysms is a special entity, needs a volume resuscitation and emergency surgery. Median sternotomy versus thoracotomy. Aortic disease proximal to the left carotid artery has usually median sternotomy, and disease is distal to this point, left thoracotomy or thoraco-abdominal incision. Surgeries of the aorta are either emergency, urgent, elective, or reoperation. Emergency surgeries in dissection, rupture aneurysm, traumatic injury, urgent as subacute dissection, expanding aneurysm, and elective stable aortic aneurysm, which is called the chronic aortic aneurysm, coarctation of the aorta, and atherosclerotic diseases, which is progressive. Reoperation on bioprostatic valve, which is a failure, graft failure, progression from one stage operation to a second stage operation, example in elephant trunk, frozen elephant trunk operations. Pseudoaneurysm is the reoperation as well. Anatomy is very important. We have to understand the relations to the aorta, the ascending aorta, and the arch and the descending, and a special emphasis on the pulmonary trunk here, which is very important next to the aorta, and this may cause compression if there is any aneurysm or any compression on this pulmonary artery. And as well, the right main bronchus is very important, which can be compressed as well, and the left atrium. Anteriorly, there is the pulmonary trunk, infundibulum of the right ventricle as well. Abdominal aorta, you should always know the level of the surgery and what extent. And if you're using endograft or stent, are we covering the celiac trunk level, T12, superior mesenteric, L1, and renal arteries are very important. And if we are covering these arteries, we should always either do reimplantation or fenestrated stents or whatever, permit some endoleak, because this will be hypoperfused and will go into ischemia. Spinal cord arterial supply is very important. It's anterior spinal artery is a single artery, and it originates from the bilateral vertebral arteries. So the left subclavian, right subclavian are very important, which give the vertebral arteries. So if we are covering the left subclavian artery, this will cause a big left subclavian artery give big problem if this spinal artery is compromised. And for the posterior, this covers the anterior 2/3 of the spinal cord, and the posterior spinal artery covers the posterior third, originating either from the vertebral arteries as well, or posterior inferior cerebellar arteries. And these are two posterior spinal arteries. The very important is the segmental arteries. These segmental arteries are end arteries, and whenever we compromise the segmental arteries, cover them with stents, or do much of a dissection during surgery, these are compromised, and these are end arteries which affect the spinal cord massively. And they are branches of deep cervical, ascending cervical, intercostal, and lumbar arteries. The one important artery is the artery of Adamkiewicz, or the arteria magna, which arises between T9 and T12, sometimes distal to this, but it's very important because it also has anastomosis with the anterior spinal artery, and it supplies the anterior part of the spinal cord, distal part of the spinal cord. Histologically, we should know that the aorta is endothelial or intima, media, muscles, adventitia, which are connective tissue. We all know this. We start with the aortic aneurysm as one entity, and the first entity. What's the aortic aneurysm? It is definition. It's the dilatation of the aorta, which contains all the three layers of the vessel wall. So, as we said, all these three layers should be dilated. Whenever they have the dilatation of the three layers, it is an aortic aneurysm. So what is a pseudoaneurysm? Pseudoaneurysm is not that. It's not all layers are dilated. There is localized dilatation, not all three layers. and contains clots, and it is contained by connective tissue surrounding the aorta, and this is usually caused by contained rupture of the aorta, intimal disruptions, penetrating atheromas, or partial dehiscence of a suture line, and this is very important and dangerous as well, and they may lead to reoperation. What are the causes of aortic aneurysm? Atherosclerotic aortic dissection, collagen vascular disease as Marfan's syndrome and Ehlers-Danlos syndrome. Marfan's is well established now in the guidelines and has its own entity with dealing with the Marfan's and the dilatation of the aorta and the dissection and aneurysms, but Ehlers-Danlos is still not as established as the Marfan's in terms of the guidelines. Trauma, cystic medical degeneration, infectious as bacterial, viral, spirochete, syphilitic, fungal, and inflammatory as Takayasu arthritis and the polyarthritis. And we can see some of these inflammatory diseases affecting the aorta, causing ulcers, causing dissection as well. The shape of these aortic aneurysms are either saccular, as we see here, this is the saccular part, or fusiform. The most common is the fusiform, and it is associated with the atherosclerotic or collagen disease, and usually longer segment. Saccular, small segment, and it is confined to the isolated segment of the aorta. What are the symptoms of the aneurysm? Chest back pain caused by dissection, rupture, or bone erosion, mass effect on the thoracic aneurysm, which, as I mentioned before, recurrent laryngeal hoarseness of voice, trachea, main stem bronchus, pulmonary artery, dyspnea, and superior vena cava syndrome, which showed increased central venous pressure, esophagus, which shows dysphagia, and if there is any rupture, we see the rupture of the thoracic aortic aneurysm as a surgical emergency, volume resuscitation, and immediate surgery. Acute pain may be the result with or without hypotension. Rupture of the ascending aneurysm may cause tamponade, and rupture in the descending thoracic aorta may cause hemothorax, aortobronchial fistula, or aortoesophageal fistula. Whenever the patient have hematemesis or have hemoptysis, this is very dangerous sign as well. Complications of the thoracic aneurysms are rupture, aortic regurgitation, tracheobronchial esophageal compression, right pulmonary artery, right ventricular outflow obstruction. This is very important. Sometimes it causes compression of the pulmonary artery or right ventricular outflow tract obstruction, and we don't know what is the cause. We can find this in the TOE, we can find it in measuring pressures, and we should know that the right pulmonary, right ventricular outflow can be affected from mass compression, and especially in these patients, it's very important. Systemic embolism from any mural thrombus is a complication of thoracic aortic aneurysm as well. What are the interventions of the thoracic aortic aneurysms that are recommended by the guidelines from the European Society of Cardiology? Surgery is indicated in patients with Marfan's syndrome if the aortic root aneurysm with a maximum aortic diameter is more than or equal to 50 millimeters. This is class 1C, and surgery should be considered in patients who have aortic root aneurysm with maximum ascending aortic root diameter more than 45 in Marfan, more than 50 in bicuspid, and more than 55 in patients with no elastopathy. The one important things as well in these guidelines is the surgery should be considered in patients who have isolated aortic arch aneurysm with a maximal diameter of more than 50 millimeter. This is in the aortic arch more than 50 millimeters. On the descending aorta, we can see that the thoracic endovascular aortic repair, which is the TEVAR, should be considered rather than surgery when anatomy is suitable. TEVAR should be considered in patients who have descending aortic aneurysm with maximal diameter more than 55. And if TEVAR is not available in the institution, we should target 60 millimeter or more to go to surgery, because surgery is more difficult with more complications and more morbidity and mortality. When intervention is indicated in cases of Marfan or other elastopathies, surgery could be indicated rather than TEVAR. So if the patient is Marfan or has elastopathy, surgery is better than the TEVAR. What to do with the surgical repair of this ascending aortic and the arch aneurysm? It's also guided by the TOE. So we can measure the aortic valve diameter, we can measure the sinus diameter, the sino junction between the sinuses and the ascending aorta and the ascending aorta as well. And according to the affection of these diameters, we'll decide the type of surgery upon the diameter. Perioperative TEE is very important for this, as we said. You either do surgery only for the ascending aorta, or can you include the root of the aorta, which is the sinus till the sinoaortic junction. What type of surgery here? So if the aortic valve is not involved, and the ascending aorta is only involved, we can replace the ascending aorta with a tube graft only. But if the aortic valve is diseased, but the sinuses of Valsalva, which is the aortic root, are normal, and aortic valve replacement combined with tube graft for the ascending aorta. But if all are involved, this is requires root replacement. This is very important. You can see this severe dilatation of the root here. So this is the bisinus diameter or the aortic diameter, which is enlarged in this patient, and the ascending aortic as well. Aortic root replacement, which is the modified Pintal procedure. We all hear about the modified Pintal, and with this we replace the aortic root and we do reimplantation of the coronaries, plus or minus the valve replacement in the aortic valve. If this pathology extends to the aortic arch, this will take us to the repairing the aneurysm with deep hypothermic. We use deep hypothermic circulatory arrest with perfusion adjuvants such as selective perfusion of the innominate or of the left common carotid. And this is one example of operation which is called the elephant trunk repair operation, with the involvement of the aortic arch in this patient. We can see different types of grafts here. So tube graft with trifurcated branches, which is a branch with from this tube graft arising from it, and then we can connect the left common carotid and the left subclavian to the same graft, which replaces the innominate. So it is a trifurcated tube graft, and it is replacing here part of the arch of the aorta, and this distal part is another part of the surgery, which is frozen elephant trunk for this patient, and its extension of the dissection into the distal part of the thoracic arch and the aorta. Very important here are the surgical techniques in the aortic disease. What we should use according to the guidelines. These 3 arrows represent the most important for the anesthesis. CSF drainage is recommended in surgery of the thoraco-abdominal aorta to reduce the risk of paraplegia. Very high instance of paraplegia in these surgeries. Selective antegrade cerebral perfusion, which is selective perfusion or antegrade cerebral perfusion, should be considered in aortic arch surgery to reduce the risk of stroke. This is 2A as well. And left heart bypass should be considered during repair of descending aorta or the thoraco-abdominal aorta to ensure distal organ perfusion, and this is 2A as well. We then touch the anesthetic management for the ascending aorta and the arch aneurysms. The imaging studies should be reviewed before surgery in an MDT with the surgeons, and see if there is any compression of any mediastinal structure, such as the right pulmonary artery, the left main bronchus. This will affect our intubation, will affect our ventilation, and will affect our measurements. And even the TOE, sometimes we put the TOE in the esophagus, and when we try to push it into the stomach, it stops. Just because this is a very huge aneurysm that is compressing the esophagus. So in this patient, just stop. Don't cause any harm to the patient by pushing the TOE. You shouldn't obtain the transgastric views at that point. If you feel any resistance, you already passed in the esophagus and you have the esophageal views, you can use them, okay? Don't push the TOE at that point. It will cause rupture of aneurysm. Prevention of hypertension increases it's very important. So increases the forward flow in case of aortic regurg, minimizes the risk of aneurysm rupture as well. We should have a proximal and distal aortic arterial management, either in the right radial artery, and if we are using selective perfusion, to the innominate artery or the axillary artery, we should obtain a left radial artery or a femoral artery, so distal to the perfusion, to know the distal perfusion pressures on bypass. If arterial cannulation of the axillary subclavian or innominate, we said that we should do opposite cannulation. Very important is the temperature, nasopharyngeal, tympanic, bladder temperatures, important for the brain and for the maintenance of the core temperature and the conduction of deep hypothermic circulatory arrest. TOE is very, very important. It guides you, assess the surgical intervention, guides the plan, confirms diagnosis, guides the plan, and monitor the outcome. In patients with AR, it is very important in the delivery of cardioplegia if we do retrograde cardioplegia cannula. TE is reasonable in thoracic aortic procedures, which includes endovascular interventions. It's very important if you want to guide the guide wire during the TEVAR procedures to use the TOE and ensure that this guide wire is in the true lumen, not in the false lumen, because if you put the guide wire, you put the sheath, you put the stent in the false lumen, and you deploy the thing, you will end with rupture of the aorta and sudden death. Neuroprotection is very important. Brain protection here, what are the important things that we do for neuroprotection? Deep systemic hypothermia is important. Topical cerebral cooling. Usually the surgeons believe in topical cerebral cooling more than us, to be honest, but we still do the topical cerebral cooling, okay? Retrograde cerebral perfusion and selective antegrade cerebral perfusion and cerebral hypothermia at any point should be avoided during rewarming. What's the deep hypothermic circulatory arrest? We should maintain the median nasopharyngeal temperature at around 18. Best is 12 or 12.5 degrees centigrade to produce silent EEG picture, but 18 is a median nasopharyngeal median temperature with good suppression. Very high silence production in a high number of patients. Nasopharyngeal temperature 12.5 is the best, and either 12.5 or cooling the patient for 15 minutes achieved 99.5% of the cases. So this is very important, but it has its drawbacks: coagulopathies, organ perfusions, and other complications as well. And the second approach is the retrograde cerebral perfusion. Here we just do infusing cold oxygenated blood in the superior vena cava, so retrograde from the pump to the superior vena cava, and then going the brain in the opposite direction, from the superior vena cava to the internal jugular vein and to the opposite direction. And this is a temperature of 8 degrees to 14 degrees via cardiopulmonary bypass. And this is very important, and we should monitor the CVP at that point. It shouldn't be exceeding 25 centimeters mercury. So this is a new terminology which has been introduced, which is the goal-directed cerebral perfusion. Goal-directed cerebral perfusion means antegrade cerebral perfusion plus nearest monitoring or near-infrared spectroscopy monitoring. So selective antegrade cerebral perfusion and near-infrared spectroscopy together is the goal-directed cerebral perfusion. What's the pharmacological neuroprotection? We know the thiopentone. Thiopentone at 15, we used to, when it was available, it was 15 to 20 milligrams per kilograms on bypass, and this can augment the 18 degrees patients which are not yet in silent EEG and can augment them to the silent EEG stage. Propofol causes suppression and it doesn't cause silence, and corticosteroids. Corticosteroids are established in the spinal cord protection, but they are controversial and they may cause harm in the brain protection, especially if they cause hyperglycemia. What are the acute thoracic aortic syndromes? These are syndromes which are emergency conditions and have similar characteristics involving the aorta. There is a common pathway for all of them, which initiates, and it includes the breakdown of the intima and the media for all of them. This is the classification of the aortic acute aortic syndromes, class 1, 2, 3, 4, 5. Class 1 is the aortic dissection with true lumen and the false lumen. And this is the entry point here. Class 2 is the intramural hematoma, which here. And class 3 is the subtle or the discrete aortic dissection with bulging of part of the aorta. And the class 4 is the penetrating aortic ulcer. As we can see, it penetrates into the media here. And this is class 5 is the iatrogenic or traumatic aortic dissection, which is we usually see in cath lab. This is a picture of the intramural hematoma. Another picture of the atherosclerotic ulcer, which is penetrating or into the media here, and it may cause intramural hematoma, dissection, aneurysm, or rupture. And we all know that what happens in the aortic dissection is increased pressure at the intima, okay, from the entry point here, which cause tear, false lumen into the media that may propagate, and it may either come out again into the intima with a re-entry point. So this is an initial tear, and maybe there is a re-entry point here, or it may stay without a re-entry point. Location 65% in 3 centimeter distance from the coronary ostia, 10% in the arch, 10% in the descending thoracic aorta. What are the management of this acute aortic syndrome? So these patients come typically with acute chest pain. So we should manage this patient by seeing the patient, note what if it is a high risk patient for developing acute aortic syndrome or not. So what are the high risk conditions? High risk conditions are the Marfan syndrome, family history of aortic disease, known aortic valve disease, known thoracic aortic aneurysm, previous aortic manipulation, including cardiac surgery as well. High risk pain features, chest, back, abdomen, abrupt onset, severe intensity, ripping or tearing pain, high risk examination findings, evidence of perfusion deficit as a pulse deficit, systolic blood pressure difference, focal neurological deficit in conjunction with the pain, aortic diastolic murmur, which is new and with pain, which may signify acute aortic regurg, hypotension or shock, which may signify any bleeding in an aneurysm or dissection as well. What is this the algorithm for the acute chest pain? Take medical history of the patient, clinical examination, as we said, and ECG. If this patient is STEMI, see the ESC guidelines, which measure acute coronary syndrome. If not, see if the patient is hemodynamically stable or not. If unstable, start with transthoracic echo. If you can see a good diagnosis and confirmed, just go to theater. If it is not confirmed, you should do TUE or CT if the patient can reach the CT. And if it is excluded at this point, you should see another diagnosis. But if this patient is stable, here we have to go back to this slide. Is it high probability or low probability? High probability, score 2 to 3 from the previous ones, and plus or minus typical chest pain. Typical chest pain alone is okay, or this high probability score alone is okay. Low probability score 0 to 1. If this is a high probability score, due to thoracic as a beginning, definite aortic dissection, refer emergency to the surgical team. If this is not the case here, and there is inconclusive, just go to CT or TOE if the patient is unstable, and then we can confirm aortic dissection or can search for another diagnosis. If there is low probability, just start with the less invasive things, or D-dimers, for example, transthoracic echo, chest X-ray, and combine the 3 of them in your results. D-dimer is very important in the aortic dissection, especially shooting numbers in the first hour of the pain. If you have shooting numbers, very high numbers during the first hour after the pain, this is a very good guidance towards aortic aneurysm. If there is other investigations. So if D-dimer is negative, transthoracic negative, chest X-ray negative, no argument for this aortic dissection, consider another diagnosis. But if there are widened mediastinum signs of aortic dissection from transthoracic high D-dimers, go to CT, and this patient should be stable, can do MRI or TOE as well. MRI usually takes time and needs more stable patients. Confirmed, plan as well, and not confirmed, consider for another diagnosis. Detailed imaging is very important in this patient, so you should visualize the intimal flap, extent of this disease according to the anatomy for the plan of the surgery, plan of the anesthesia, identification of the fourth and true lumens, localization of the entry and re-entry tears, as we said, identification of antegrade or retrograde dissection, identification and the grading and the mechanism of aortic regurg, is this valve is healthy or not, involvement of side branches of the aorta, detection of any malperfusion in the mesenteric or vessels or in the celiac or in superior mesenteric, whatever, renal, this is very important, the brain as well, detection of organ ischemia as brain, myocardium, bowels, kidneys, detection of pericardial effusion if there is tamponade and severity, detection extent of pleural effusion, detection of aortic bleeding and the signs of mediastinal bleeding. All this in aortic dissection you should have a modality that gives us all this information. If you cannot obtain it by CT, you should obtain it by TOE before surgery or during surgery. Intramural hematoma, its localization and the extent coexisting of atheroma, presence of small tears are very important as well. And this is a comparison from the guidelines between different types, transthoracic, transesophageal, CT, MRI, and aortography. For the ease of use, transthoracic, of course, bedsides, but for the accuracy, reliability, TOE, CT, MRI, and for the follow-up, the best is the MRI in the serial examinations and in the wall visualization. CT is good as well for the TOE in the aortic visualization, but the best for the follow-up is the MRI. This is an example of aortic dissection by transthoracic echo. You can see the intimal flap here, for example, in this picture. And this is the transesophageal echo, the intimal flap and the entry point. And this is the intimal flap as well, true lumen and pseudo or false lumen. All these are examples, intimal flap, and these are very important diagnostic tool and follow-up as well. How to differentiate true lumen and false lumen? So the true lumen has pulsation, systolic expansion, but the false lumen has systolic compression. Flow direction is antegrade in the true lumen. It's antegrade reduced or absent in the false lumen or even retrograde. Communication flow from the true to false lumen in systole, and this is very important. And the contrast echo flow is early and fast, which here is delayed and slow. This is always the true lumen is smaller than the false lumen, but you can see here this is more sluggish in the flow, more brighter, and may contain thrombus as well. This is a picture of the intramural hematoma here, and this is as well another one here, and this is the penetrating ulcer in the aorta. So what's the classification of the aortic dissection? And we can localize it by this classification. The most important is the Stanford classification. For these guidelines rely on the Stanford classification. Stanford says that you have type A and type B. Type A is localized or affecting the ascending aorta proximal to the left subclavian, but type B is always distal to the left subclavian. But you may have an origin of the entry point or dissection here in the descending aorta, but it extends and involves the ascending. At that point, it is type A because it affects the ascending or the arch of the aorta. Okay, the Becky as type 1 and type 2 and type 3, and this type 2, sorry, is localized to the ascending aorta. Type 1 involves all the aorta, and the type B involves the aorta distal to the left subclavian, and it's either at this level, proximal or distal. What's the presentation? Chest pain, back pain, migrating pain with the ingoing dissection, aortic regurg, tamponade, ischemia or infarction, heart failure, pleural effusion, syncope, major neurological deficit, spinal cord injury, mesenteric ischemia, acute renal failure, lower limb ischemia. The differential diagnosis is very important, and we said that when the investigation, D-dimer is one of the very important markers. There's also other new markers which result from the destruction of the aortic media, but this is beyond the scope of our lecture. This is the importance of CT evaluation in the aneurysms. Treatment of the aortic dissection. Here it is very important that all patients with aortic dissection, medical therapy targets pain relief, blood pressure control. This is the first thing. In patients with aortic dissection, urgent surgery is recommended. In patients with acute aortic dissection or malperfusion, we may do a hybrid approach, such as ascending aorta or arch replacement associated with any percutaneous TEVAR, for example. In uncomplicated type B, medical therapy is level 1C. In uncomplicated type B, TEVAR should be considered, is 2A. So we have two opinions with different levels of evidence for the type B. Type A, always surgery. If this is uncomplicated, but in complicated type B, TEVAR is recommended. And in complicated type B, surgery may be considered, but TEVAR is 1C better. Treatment of this dissection, according to the Stanford A, considers surgical emergency, and there is 1% mortality per hour for the first 48 hours, so 50% mortality in 2 days. And despite improvements in surgical anesthetic techniques, perioperative mortality and neurological complications are still 18%, neurological and mortality 25%. Operating type A presenting with neurological deficits or coma is controversial. So if you can do it in the first 5 hours, you can. If not, it's very poor prognosis. What are the types of surgery in the aortic root dissection? This is if we have aortic root dissection, we either do a valve sparing technique as this one. So concept of valve sparing root repair, excision of the diseased aorta and isolation of the coronary arteries. And also we may do reimplantation of the coronaries into the tube graft here, which is either David operation, and the David operation has support of the annulus, or in the Jakob operation, which has no support of the annulus. Ascending aorta and aortic arch surgery, and these are examples all of the types of the tube grafts here. In the distal arch and in the descending aorta, if you can, you know that the entry point is here in the descending aorta, you can use the two-staged hybrid elephant trunk operation, or the one-stage hybrid frozen elephant trunk operation, and you at this point you occlude the entry point, which will not affect your graft here after the first operation. This is a patient which was 56 years old male, presented with subacute type B dissection. He was hypertensive, persistent chest pain, creatinine is 2.7. So this patient is considered unstable type B, as we said in the guidelines. And the term complicated or unstable means persistent recurrent pain, uncontrolled hypertension, malperfusion, which is the creatinine high. So this patient, continuous pain, creatinine high, is complicated. This is the two types of stent grafts that we use. And this is a case that we did already previously. It was a hybrid case with TEVAR and arch debranching from the neck incision. So we did debranching from the neck incision with the hybrid thing from the femoral approach. This is the primary tear here in the CT. We can see that the CT tear is involving reaching the left common carotid. So if we put here, and this is the primary entry site. So the primary tear is here, but this is still there, and we should have a landing point of around 2 centimeters if we use the stent here. So we're putting the stent to cover this point. Until this point, we will occlude the left subclavian and the left common carotid. So what we did is that we opened through a neck incision and did debranching of the left subclavian and the left common carotid, and connected them with tube grafts to the innominate artery, and did the TEVAR from the distal side. So this is the complete picture of the CT with the dissection. What we did is putting the stent here, occluding the primary entry point, and this false human will thrombose. And this is the picture here, left subclavian, and this is the left common carotid and connected by tube graft to the innominate artery. And this is the stent here covering this part of the aorta. We did this case in Alexandria, so we used all the available things. So it was like a monitors, nearest. If we see here that the left side of the brain, right side of the brain, and this was distally in the lower limbs, and this was the dissection of one of the iliac arteries. So this is lower than this in the reading, and this was after occluding the left side. We can find that it dropped on the left side for some time, but still 58, which is fine. And this is after reperfusion again, it's almost equal again. Using the TOE to define the entry point and to guide the processing of the guide wire and the catheter to the true lumen. And this was the final part, surgery, the tube graft from the neck incision in a hybrid procedure. And this is the stent graft. This is the aortography in the cath lab. This is the branch here, and this is the stent graft. And this is the whole length from the inferior part. The last thing is the thoracoabdominal aneurysm. We should know that this is a Crawford classification for this, which it's either 1, 2, 3, or 4. It's either starts below the subclavian artery origin and ends in the above the renal artery. This is 1. Entire descending thoracic aorta up to the bifurcation. 2. Starts at distal thoracic aorta involving the abdominal aorta. 3. Confined to the upper abdominal aorta is 4. And this is the figures here. Descending thoracic and thoracoabdominal aneurysms. The most important things that there is risks for spinal, mesenteric, renal, and lower extremity ischemia, significantly due to the thromboembolism, loss of collateral vascular network of the spinal cord, as we said before, and temporary interruption of the blood flow. And these are the complications: cardiac, pulmonary, hemorrhage, acute renal failure, paraplegia, and in-hospital mortality with the thoracoabdominal aneurysm. This is the position. This is the position, the direction of the aorta, the course of the aorta, I mean, and the position is usually 30 degrees in the hips, 60 degrees in the shoulders, a thoracoabdominal aneurysm, which is extensive one. We use certain maneuvers to perfuse the distal parts. It's either we use the left heart bypass for the thoracic and thoracoabdominal replacement, and we use this from the example from the ascending aorta, or from the bypass to the distal part of the body, bypassing from the pulmonary veins, for example, with the left heart bypass from the pulmonary veins to the distal parts, or any of the arteries in the distal abdominal or thoracic aorta. This is a left heart bypass as well, and we here is using thoracic and thoracoabdominal replacement with selective visceral perfusion. And there is selective bilateral cold saline infusion of the kidneys. This is another maneuver to protect the kidneys as well. So all the arteries, left renal, celiac, superior mesenteric, right renal, all of these arteries should be either perfused or protected. We may use somatosensory evoked potential for the spinal cord, motor evoked potential, NIRS, lumbar CSF pressure, body temperature, and this is a picture of the loss of the motor and potential, and this is loss of the somatosensory evoked potential. So this is the normal course, and this is here the stoppage or the abrupt, and this is the abrupt stop as well in the somatosensory. This monitors the dorsal column, this monitors the anterior part of the cord, and this should be without any muscle relaxant in the motor one. Spinal cord is very important. Blood supply, perfusion pressure, reperfusion injury, critical intercostal artery coverage. So if we are covering a large area of the aorta, the more incidence of the spinal cord injury we have. At this point, we should either use fenestrated stents, we should use bifurcated stents and anastomosis with these branches, or we may allow some endoleak inside the stents to perfuse from around to these arteries. Collateral circulation of the spinal cord and the hypotension. Avoid hypotension in the first 48 hours. especially in the ICU. We usually forget this in the ICU. There is always spinal CSF drainage and avoiding hypotension, blood pressure above 80 in the ICU for first 48 hours to protect the spinal cord. This is another method to monitor the collateral circulation here of the spinal cord with the neurons as well on the paravertebral planes. And this is to the areas of anastomosis that may be affected. Hypotension, we mentioned this, and reimplantation of the vessels, all of them. If you can reimplant the vessels, reimplant. CSF drainage is very important in this part, and this is the endoleak that we can permit for 5 to 10 days, and then we can use the amplazer to close these endoleaks later on when we are sure that there is no paraplegia and no affection of the spinal cord. CSF drainage is very important. You should ensure that there is no coagulopathies and it's maintained for 48 hours. You should monitor this. Pressure should be less than 10 to 12 millimeter mercury at all time. Take home message. You should know about the aortic clinics, aortic teams, acute chest pain algorithm, pre-assessment. There should be MDT, patient involvement. Always think A, B, C, D, E, F, G, pre, intra, and post-operatively. Follow the guidelines, and future is for the cath lab and the hyper procedures as well. Thank you very much.
Barbara?
Thank you so much, Dr. Hashim. Let me see what kind of questions we have from the audience. Here's a question from the audience. It says, is the silent EEG and burst suppression the same thing, or are they different?
No, they are different, and they are not the same thing. We can obtain silent EEG with hypothermia or deep hypothermic circulatory arrest, or we can obtain this with the thiopental sodium as well. So the only drug which is similar to the hypothermia in producing the silent EEG is the thiopental. Burst suppression is different and is less protective for the brain than the silent EEG, definitely.
Thank you. And there's some more questions from the audience, please.
Sorry.
I think the audience enjoyed the lecture too much, and because the lecture is very informative and is delivered in a fantastic way by Prof. Amr Hashim. What do you want to add, Barbara? If you want to ask anything yourself?
Sure, I will ask a question. In your institution, do you place the CSF drains, or does the surgeon?
No, we do the CSF drainage. We usually do the CSF drainage. We can use the special catheters for the spinal catheters that we use, and we put them on monitors, monitoring the CSF pressures, the same as the CVP measurements. And these special catheters will allow the drainage as well. We usually start with draining like 20 mils these patients, even with the low pressures, and we just monitor after that for 48 hours.
Do you normally drain a certain amount each hour, or do you wait until a certain pressure is reached?
It's better to wait for, it's two different schools, to be honest. So there are school which says every hour you have to take like 10 to 20 mils of CSF, and this is better even if the pressures are fine, because it's always about the perfusion pressure of the spinal cord, the difference between the mean arterial blood pressure and the CV and the cerebrospinal fluid pressure. So you cannot always ensure that your map is a great map and the perfusion pressure is very good. So this like routine or sequential draining is better. Others just go by the pressures measurements, and we usually go by the monitoring of the pressure measurements, unless there is a definite sign of paraplegia or affection of the limbs.
Okay. And here's a question from the audience. The audience asks, what is your target blood pressure?
Target blood pressure for the spinal cord should be above 80 to ensure that there is a good mean arterial blood pressure above 80.
Okay. Here's another question from the audience. It says, Doctor, please mention your fluid regimen and your analgesics post-operatively, please.
Because in our institution, they use the either the IV opioids infusion, which is the either fentanyl or alfentanyl infusion for these patients, and we usually avoid regional techniques because of the coagulopathies and the these patients bleed like hell, especially the thoraco-abdominal patients. Requires like massive blood transfusion, massive products. You cannot rely on any regional block for these patients. So usually use the IV opioids infusion for these patients, and the paracetamol is usually we give paracetamol as well, and then these patients on the second day we usually put them on PCAs, PCA morphine or PCA fentanyl, and then start weaning the continuous infusion, relying on the PCA, and then the oral opioids thereafter in combination with the paracetamol, and we may give gabapentin and other drugs, which if there's no contraindication for the neuropathic pain.
Wonderful. The next question from the audience was basically the same. They were asking if you use PCA, which you said you do use PCA.
Yeah, we do.
Let me see if there's another audience question here. Here's an audience question. Any contraindications for the CSF catheter in patients with pre-existing coagulopathies?
In these patients with the pre-existing coagulopathies, it's very difficult to put a CSF catheter. And if this patient can be corrected pre-operatively, it is better if you can give any time. If it is emergency, we can do nothing and we should avoid it. But if there is a possibility for correction of the coagulopathy, if patient is on warfarin and he's a chronic patient and maybe stable, we can give periplex or prothrombin complexes for these patients and reverse it. So it's better always to use it, but if you can't use it, the paraplegia incidence is very high in these patients with extensive manipulation of the blood supply of the spinal cord.
Thank you. Is there any other questions from the audience, please? Well, thank you so much, Dr. Hashim. That was a wonderful, wonderful, informative lecture.
Thank you so much. Thank you so much.
Thank you much, everybody. Today we have another milestone, a great lecture by Prof. Ansari and his series in intensive care, and another very, very informative lecture by Prof. Amr Hashim, his first day today with us, and we hopefully will see him again in another series of open heart anesthesia. And wonderful moderation by Barbara Roger from Ohio. And thank you very much for coming today, and hopefully we'll see you again. All our colleagues and attendees, happy Eid. And next Sunday and the following Thursday, next Thursday and the following Sunday, we are off. And we see you all on Thursday, 6th of August. Thank you very much.
Yeah.
Okay, happy Eid. Thank you. Thank you.
Thank you.
Thank you.